Hello everyone, I'm Tess Hewitt. I am the Global Fund, which I'll explain later, a link between all of MSF. So I'm not tied to a section or a OD. I will do a brief introduction, but I think I'll hand over for introductions of others first.
Yeah, hello, I'm Roz. I sit in the MSF UK HARP team, which is like every word under the sun. It's like humanitarian affairs, analysis, advocacy, representation and policy, or something like that. So we do like policy analysis, advocacy and representation in the UK towards UK government, UK stakeholders, and I'm the access to medical products and global health policy lead.
Hi everyone, I'm Charles Sonko. I'm the chronic care and infectious disease team lead. I'm based in the Manson unit, but I'm also one of the HIV/TB advisors. So I also cover Somalia, Democratic Republic of Congo, and I've been advising Ethiopia, South Africa as well. Yes, please.
So my name's Liz. I lead on the HARP. I also are the representative to the UK government for them.
Lakshmi?
Thanks. I can't see the room so well, and sorry I can't be there today. My name's Lakshmi. I work now on medical content and advocacy within the Manson unit that I hope you all know well and sits within MSF UK. I did work as a HIV/TB program implementer for about 4 years, and so we'll bring some of that experience to this as well. Thanks.
Great, thank you everyone. Just to say, this came about because as I said, I'm from the UK. I lived some time abroad and so forth, and I'm very aware that I don't really engage with the UK office at all. In fact, like there's this whole team across MSF covering like global health and so forth, and I'm not engaging at all with MSF UK. However, there are individuals across MSF UK which we all are interacting in terms of the global health response, and trying to look at what's happening at the moment in terms of the aid cuts that I'm sure you're aware of and familiar around, and we really invite your questioning about that afterwards to hopefully provide some sort of clarity, and looking at how this impacts on MSF in terms of the people that we're really working for in the projects and countries where we are. And HIV, we've chosen HIV as sort of a lens to try and illustrate how those cuts impact on the people that we're working with in the countries where we are. And everybody here is working sort of as part of the wider puzzle, like we're all a piece of the puzzle of how to understand that and analyze and see what we can do about and advocate as well for those people and populations. So I am going to hand over to Charles first as the Lakshmi, sorry. First, so just hone in a little bit more on HIV, as I said, as an example, so you can get a scope of what's at stake for the HIV response in terms of the cuts that are taking place worldwide.
So we'll just explain a little bit about how our role connects directly. So I hope I can speak for Charles as well a little, in that we are involved with kind of lots of person and patient related activities. That means kind of the programs in the projects where patients are being tested for HIV, they're being put on treatment, and they're being kind of supported to stay on treatment. And my role has quite a lot of impact, as do the other advisors, on how that kind of works in terms of on the ground in the projects. It'd be nice to just talk about a little bit how we all relate to person X. So I'm going to hand back to Tess a bit on how that works. Thanks.
Okay. So I've got a bit confused, Lakshmi. So if in terms of person X, so the idea is we'll go through and we'll illustrate how each of our roles interact again with the person at the heart. So the population, the people at the heart of the projects of MSF. And again, we're focusing on HIV, but you could pick any like health topic issue related to the people where our projects are. And we, in all our roles, interact with this person, right? So we're just trying to tie up all the dots of the global health cuts and the global health structure system and how it relates to patient X, to the individual, the patient at the heart of MSF.
Okay.
So, Lakshmi, do you want to take over on that?
So if we just go to the next slide. Thanks. So I think it's really it's interesting that we've picked HIV, and I wanted to kind of be all on the same page about why this is a good example, because HIV, we might not hear about it as much as we did kind of back 50 years ago. MSF was really pivotal in a lot of the work we do with HIV in terms of getting access to really important medications, treatment called antiretroviral therapy that stops HIV being an issue. Really, we should think of HIV as a thing of the past in 2025 because we've got lots of tools. I'll mention really briefly here something called undetectable equals untransmittable, which I hope is in all of your minds already, but I think it's an important thing to kind of really emphasize that patients now living with HIV, especially in places like here in the UK where I work in the NHS, don't really think about having HIV. They take their medications every day. They get the virus undetectable, which is what this kind of advocacy refers to, U equals U, and then they become untransmittable. And I just want to be really clear that that means they cannot pass it to anybody. So mothers can't pass it to their children, partners can't pass it to people who don't have HIV. So really, with those tools, and we've got really good prevention tools, which I'll talk about too, we shouldn't really be thinking about HIV, but it still remains a huge global health emergency. I've put a few stats here just to kind of highlight that we're still getting 1.3 million new infections every year, and it's kind of key groups like adolescent girls and women, where they're 3 times higher and more likely to get HIV than their male peers. It really, really kind of focuses in on marginalized and criminalized populations. They've got double the chance of getting HIV. And I think it really highlights these persistent gaps in prevention and service access. So I think while we've got the tools, we really need these people to stay on treatment, and HIV prevention is key. And Charles will go into a little bit more about how that really relates to our projects. Can we have the next slide, please? So it is exciting times. HIV prevention isn't a new thing. It's been around for over decades. In terms of oral prevention, patients take a tablet daily, and that has been very effective at reducing the effect of HIV. People aren't great at taking pills for any illness, so there have been different efforts to kind of introduce different modalities that people can use to prevent their risk of HIV, including a ring that you can see on the picture here, and injectables, which is really what has got quite exciting at the moment. I think the key thing with this is there are very few interventions in medicine that almost reduce your risk of HIV to nothing, but injectables are one of them. Next slide, please. So I'm just going to very briefly talk about long-acting injectables and why they're great. So if you think about it, essentially taking pills pretty much every day is subject to kind of human error, and it's quite hard to stay on a treatment or a preventative treatment every day. So having to take cabotegravir, which is an injectable that was developed in the last couple of years, or lenacapavir, which is newer and you need to take it less times, like every 6 months, it actually makes life much easier to take. This is particularly relevant if you think about some of the projects where MSF are working, where conflict and instability mean that you might not be able to get access to your meds, you might lose your medications, or you may be subject to violence and sexual violence and things where you need to empower and protect yourself. So long-acting injectables really are game changers and something that we can really think about as key to supporting mobile populations, key populations and marginalised groups. Next slide, please. Over to Charles.
Thanks, Lakshmi. So what are the realities of persons in humanitarian and conflict settings? So as you know today, MSF focuses more in conflict and fragile settings. That's where we have our HIV projects. For example, we have projects in South Sudan, we have projects in the Democratic Republic of Congo, As you know, what's going on there at the moment, they are all in the middle of conflict. Our mode of operation is mainly integration. So what does that actually mean? It means treating HIV together with the other medical activities. So sometimes this comes with challenges. Basically, in such situations, we have competing priorities. In ideal sense, every person walking in front of us, we need to offer a test and treat them with HIV. But due to sometimes competing priorities, there's some challenges that sometimes HIV could also be deprioritized. We do work in collaboration with the Ministry of Health. Over time, MSF used to respond to huge cohorts of patients when there was nobody to treat HIV. But at the moment, we do collaborate with the Ministry of Health, with Global Fund and other funders like PEPFAR and other organizations. And actually, we've shifted from dealing with everybody, but hand over stable patients, but continue to support the Ministry of Health. Meanwhile, we cover the gaps and focus on the vulnerable groups. And so these are some of the vulnerable groups. So we work with key populations, LGBT, sex workers, survivors of gender-based violence, since we're on the front lines. Those that are undiagnosed and untested, these are where there are gaps and Ministry of Health cannot cover the testing. Those on treatment and virologically unsuppressed, these are people that are more vulnerable to the disease progressing and transmitting HIV as well. Partners of children, of people living with HIV, and women and children. So there are so many barriers that these groups face, especially access being one of the main ones. But these are mainly due to, because these groups are very stigmatized, more marginalized, but also discriminated. For example, key populations, we know in many countries they are marginalized and criminalized. Due to instability, there are so many barriers due to that. Access becomes an issue. People cannot pass barriers during war. So MSF is always there, sometimes, most of the time, covering the gap. So, yeah, so other challenges for our populations here include supply chains. You know, this is getting worse due to the funding cuts. We see lots of stockouts, prevention, treatment of opportunistic infection is missing from most of these patients. We cover advanced HIV because Global Fund cannot cover those aspects. All these issues result in treatment interruptions, progression of disease, and ongoing transmissions, which actually comes back to the equation that we need more prevention and more treatment, which can actually become much more expensive. So the game changer here is if we get prevention treatment widely scaled, I think this is one way to actually getting to zero at some point with HIV. We know this type of treatment, the long-acting treatment, empowers groups, especially the women, as Lakshmi has mentioned. So I'll stop here, and I think we'll show a video that will capture a bit of projects where we've implemented some of these long-acting tools.
Let's do it. Oh, like there. Do that for some. Oh, 1 second. Yeah, can I share the video in the chat instead? Is that okay?
Yeah. Do you want me to?
Oh, really?
So you bottom right, it says my computer. I think you should stop sharing them.
Nice.
Yeah.
When I because I my Anyway, one of us will be there.
Injectable PrEP has the potential to end the HIV epidemic, but it will only end the HIV epidemic if people are getting it. We are supporting the rollout of Cabalé in 4 countries in Southern Africa, so Mozambique, Malawi, Zimbabwe, and Eswatini. So we do expect Cabalé to be a game changer, and I don't think we are using this word lightly. We need to focus on the populations at high risk.
Ngathukela sengibangela ukuthi ngifike ku-PrEP ukuthi manje i-relationship yami bengikuyo isekutheni manje lona lengithandana naye ufike esigabeni lapho khona kutholakala ukuthi yena is HIV positive, kanti mina ngathi ngangifika esibhedlela ngiyotesta ngatholakala ukuthi manje ngi-negative. Ukahle kakhulu kwenza ngokuthi manje sotawuhlala njalo unathane amaphilisi ngaso sonke isikhathi. Uyadihlola wathola ukuthi manje ude leli gciwane. Qhubeka uhlale ude leli gciwane.
Cabalé is one of the most effective method of preventing HIV because it is in the system. There's no way you can forget it. It's actually 80% effective more than the oral PrEP.
You know, it's safe to say that if there is access, wide access to injectable PrEP, it is possible to end the epidemic. We do expect injectable PrEP to be a turning point in the history of HIV. Injectable.
Okay. Yeah. Okay, so yeah, I mean, now we're going to talk a bit about how, obviously that all sounds really good, and there's lots of mention around how we could actually end the HIV epidemic if these products were widely available and where MSF is using them. But I'm going to talk a bit now about some of the access challenges that we're facing in actually getting access to those products, and then we'll talk a bit about how the cuts are impacting that even further. So it is, I think we wanted to go on the positive. There's a lot of negatives in global health policy right now, so we're kind of going on the, it's a really good opportunity if we have access to these products. It is a real positive, and if we can really push for this, it could be really groundbreaking. But the reality is that access to these products, like always with novel pharmaceutical innovations, there's huge access challenges in MSF and beyond getting access to them. So as we've been through, there's 2 products, cabotegravir and lenacapavir. So cabotegravir, Cabalé, it's an injectable which prevents HIV, but you have to take it every 2 months. Lenacapavir, as Lakshmi said, you have to take it once every 6 months. So obviously lenacapavir is better. You take it twice a year. They're saying it's the closest thing that we've ever had to a vaccine for HIV. You take it twice a year and it prevents you from getting HIV. Obviously, you have to keep taking it twice a year. So lenacapavir is obviously preferable. You have to take it less. But cabotegravir was developed and made available a few years before Len. And so we have more access to it already. And so the access challenges for lenacapavir are more severe right now. So I'm just going to go through really briefly some of the access challenges that we have to both these products, and particularly for MSF, but also beyond, and then, what we're trying to do about it, basically. So cabotegravir is particularly relevant for MSF UK because it was developed by a pharmaceutical company called GSK, who you might have heard of. They're based in the UK, and their subsidiary ViiV does a lot of work on HIV. So they produced and developed Cabalé. And so obviously our role as part of the MSF UK policy advocacy representation team is to be involved in the negotiations with GSK ViiV for access for MSF. So whilst there are really bad access challenges for access to lenacapavir, which I'll talk about in a minute, we're still pushing for access to CAB in the meantime because we have slightly more access to that. So it's being used as a sort of transition tool. So MSF, as Antonia mentioned in the video, is currently providing access to Cabalé in these countries, Mozambique, Eswatini and Malawi, and also a couple of others still trying to get access, so Kenya and Zimbabwe. Important to note that these countries where we currently have access are low or lower middle income countries. And that's quite important for some of the access problems I'll talk about later, because basically the company is very willing to give us access for low income countries because they'll just give us access for a non-profit price because they don't expect to make any money from those countries, essentially. But when we come to middle income countries, this is where access gets really challenging, because essentially you then have to talk to their commercial team, because these are countries where they want to make a profit. And so pricing becomes a barrier. So MSF has some middle income countries where we would want access, including Colombia, Honduras, Venezuela and Iran. Obviously other access challenges related to these very complex settings, but they're also middle income countries, which means that getting access through a pharmaceutical company is more challenging because of pricing barriers. And then in terms of lenacapavir, there are huge access challenges here because it's a very new medical product. It's been developed by a pharmaceutical company called Gilead, who are based in the US. So our US team is doing a lot of work on analysis around access to this. Obviously, it's preferable because of it's only twice a year, but there's enormous problems around getting access because essentially Gilead have monopolies or patents on this product, which last for over 20 years, meaning that essentially they can charge whatever price they like. And so it's extremely expensive to get access, and they control access entirely globally during this monopoly patent term. And so essentially they're controlling who gets access and when. And this is obviously a problem we've seen like time and time again in access to medical products, but we're seeing it really, really clearly here. So this is just to show, oh, I'm not moving the slide, sorry, could you do the next one? Yeah, this slide just shows actually how widely access to these products is wanted by MSF. So most of the OCs or a lot of the OCs are involved, and these are the different projects in countries that would like access to lenacapavir or cabotegravir. Some of them are already rolling it out, obviously, as you've mentioned, but yeah, it's, you know, there's a lot of projects interested, and there's a lot of places that we could use it, but there is big access challenges, which I'm going to talk about next, please. So in terms of lenacapavir, obviously the patent challenger I mentioned, so Gilead are controlling access. And so essentially, if you buy the originator product, which means you buy Gilead's product, you're looking at $28,000 per year as the originator price. So like not possible for most countries and people. If you have generics, then it goes down to $40 per year. Which is obviously much more accessible. So within this picture, what's happened is likely due to pressure mostly, Gilead has signed what we call a voluntary license, which means they've basically said to certain generic companies, we will allow you to make this product, which lowers the price substantially. But they put restrictions on which countries those generic companies are allowed to sell to. So these are some of the, oh, maybe next, if you could push, yeah. These are some of the countries who are excluded from the voluntary license. And so obviously countries included in the voluntary license include countries that they are less likely to make a profit from, so the lowest income countries. The middle income or the lower middle income countries are usually excluded from the voluntary license because they want to be able to make a profit from those. So these are some of the countries excluded. It includes countries where MSF would like to have access. And this is where it's very difficult to get access to len for an affordable price. They also have other clauses, which mean that you can't export essentially from generic companies in certain countries that are allowed to produce to countries that are excluded. So essentially, Gilead is controlling access. There's not access in many middle income countries and countries excluded from the license. Otherwise, you're looking at very high prices. Next slide, please. And then just quickly in terms of CAB, so as I mentioned, we are still working on CAB as a transition tool, and in the UK we are negotiating with them. And just to highlight like what are some of the ongoing challenges we have there. So they were happy to allow us access to CAB for the low income countries, as I mentioned, but for the middle income countries they won't even allow us to speak to their commercial team without signing a non-disclosure agreement. And what that means is that we basically have to keep everything secret, including the price that we pay for the product. And MSF, particularly in HIV, have really set a precedent in saying we do not sign non-disclosure agreements with pharmaceutical companies because we want to be able to publish the price. Because if you publish the price of medical products, it means that it's transparent. But other governments and others trying to procure medical products, including like other global health actors, are able to benchmark against what you're paying. And because obviously MSF is often able to negotiate lower prices, it's super helpful globally for others. So we kind of have a principle of transparency and publishing prices. And so when ViiV asked for non-disclosure agreement, MSF took the position of not signing it. And so essentially they have blocked us from having access to their commercial team to even discuss access to middle-income countries. So, you know, there's access problems with lenacapavir, but the access issues with CAB continue. And we're about to put a bit more pressure on ViiV to allow us to get access for our middle-income countries. But we're going to see how it goes. So just to say that because of all these quite complex access problems, the Southern African Medical Unit in MSF last year took over the HIV advocacy kind of coordination on behalf of the movement from the MSF Access team. So the MSF Access campaign, when that closed and changed to become the new MSF Access unit, HIV wasn't considered a common priority across the whole of MSF. So the SAMU team now lead HIV advocacy work, and they are actually building a really quite large multi-year project to work on tackling access challenges for HIV PrEP. And these are the kind of sections who are involved for various reasons, where the pharmaceutical company are based or other partners. These are the OCs who are involved. And obviously we also have quite a few external partners, and it involves funding about 4 or 5 civil society groups as well to do some of that work and advocacy work. So it's quite a large project, and the overall aim is obviously access to HIV PrEP for MSF projects, but also like access for all within that. And a priority target group for that is the key populations, because they're obviously excluded from so much of the access elsewhere, which I think we'll talk about a little bit in a minute. So I think now I'm passing to Liz.
So how does that really help with the UK government, and then what do we do? So with anything related to drugs, licenses, it gets really complicated because there's many parts of the UK government that's involved, and it's also kind of the way they want it. So it's not just your health people, it will be the Treasury, it'll be trade, it'll be the FCDO. I mean, so the whole cross, we will call it like a cross Whitehall thing. And they all would have their own sort of agenda, you know, and it's actually really hard to find who actually makes the decision, right? I mean, so it's actually really hard to find who to advocate to. And as Rosa said, it's actually really hard in some places to get hold of the pharmaceutical company themselves because of non-disclosures and everything. So sort of my role is very much a relationship with the Foreign Office, the FCDO. So I think for this, my angle would be, okay, particularly on the countries where I know the UK are really sort of key on, and then look at the HIV side of it, so then where they would have an interest. But also to have a look at, from a aid cut side, to actually say, well, actually, it's actually effective. Because if you only need to have injections twice a year, you know, there's actually, because they're all about effectiveness, yeah, money for output. So if you also put it that way, so trying to build the FCDO as an ally to be able to target others that are harder to target, like trade, for one, and certain parts of health as well. But really, every time that I would speak to, you know, the FCDO about, for example, like Mali, you know, I think Mali is one of the countries, isn't it? Yeah. Would be, you know, because I talk to them a lot in terms of the, you know, counterterrorism, insecurity, protection side. It's also to use those opportunities to then put a lens on it, like HIV, you know, and then that kind of draws everything together, because the whole of the UK government and each department is so siloed that they only really think about their own goals and what they're thinking now. But for this, I would also think about involving Parliament as well. So there's certain MPs, so particularly targeting the doctors. We've actually very fortunate right now, a big cohort of medical people, you know, who would be there. But we also have to have a reality check, is that UK government, pharmaceutical, you know, is a massive thing for the UK government. you know, to be able to get them to move on it. We've kind of had to put pressure from inside. So, but it's generally how we work in the HARP anyway. So I wouldn't have the technical knowledge that Roz has, but it's just using any opportunity to speak to on particular contexts, on particular realities. You know, I mean, when I first joined MSF, probably the same similar time to Charles. I mean, we were looking at refugee populations who were having to take, you know, 6 different kinds of drugs per day and runaway bags and this, and so this is life changing. You know, this is even sort of response changing. But anything we try to do, we always try to have a bit of a health lens of it. So, for example, we even managed to speak to the chief scientific advisor, you know, on Gaza, because we put it through a lens of, you know, the antimicrobial resistance, AMR, you know, so there's all possibility to be able to weave a way to get the right person to listen to. But this is going to be a fight, but it's a fight we will take on, and we'll definitely include you guys from the office as well. It might be one of the campaign mobilizations for this year, this time too. So watch this space. I think it's also good for all the departments. So it's not just a comm thing. I think, you know, our supporters have been really interested in it, you know, and wider. Yeah. Go ahead.
Yeah, okay, the next slide. So this, as I said, is really good in terms of making it relevant to the UK, because I don't have this reading. The Global Fund, which has been mentioned a few times, is it's the biggest funder of HIV, TB, and malaria worldwide. And I'm going to explain briefly why we engage with it and the links of the health cuts worldwide, and then obviously related to what you've heard about the HIV response, okay? And again, this is just an example of how we're all interconnected. And just to clarify, like Roz mentioned, for example, the SAMO team that are based in South Africa is an example of another section of MSF that's all engaged in this to make sure we have like a full reading of what's going on globally with the global health response. If you could. I have a few slides, they're a bit messy, please prompt me if it's not clear. Yeah, I get a lot of slides, generally speaking. But okay, if we go back to 2023, this slide is looking at the health funding globally, and you can see like these big donors, which now the whole system is changing, right? So these big donors on the right left of the screen, this how much they give is changing now. But you can see, for example, at the bottom, you can see the UK. You can also see the United States. If you follow the green, it goes to the HIV AIDS response. It's because they funded what was called PEPFAR, or what is called PEPFAR, I should say, which was the biggest HIV program funded by one country alone, and that's what was cut last year. So that's what a lot, when you hear about the HIV cuts for health, you link to the United States, it's about the PEPFAR funding. That is all changed now. So if we set the global health response, or the amount needed to treat HIV globally, is for this year is predicted, or last year, sorry, was predicted to be 29.3 billion. To put that in perspective, in 2022, it was only 20 billion, roughly speaking, that we got. Okay, so there's always been a cut. Forget about last year cuts. HIV, malaria, TB always had a shortfall, full stop. Last year, cuts came into place, and it really jeopardized any kind of targets. You might have heard of the Sustainable Millennium Goals, 2030 goals. It's all question mark now whether or not that will be able to be achieved. Lenacapavir included with this opportunity. Like they say, with the risk of the cuts, for example, because of what's happened, it will mean that there's an increase of 6 million infections and 4 million deaths in 2029 because of these cuts. Those cuts didn't need to take place. I mean, sorry, these deaths or those cases didn't need to take place had those cuts not taken place, right? Next slide, please. If you skip this one and go to the next one, I was trying to minimize the slides. Okay, So here again, and I'm mentioning this because you hear it a lot at the moment. You hear, okay, the bilateral and multilateral, what does that mean in terms of what we're talking about in global health funding and so forth? And you can see how the different countries took this on. Again, as I said, with the US, the 92% is because of PEPFAR, because of this very unique response agency that the US set up, at the same time as Global Fund, but it was was funded by the US, and it was 92% for the US. It was just through PEPFAR in terms of the HIV response. And then you can see the UK, in contrast, the UK response to HIV was to go for multilateral. And multilateral includes, if you could go to the next slide, the Global Fund, okay? So the Global Fund, as I said, is the biggest funder of HIV, TB, and malaria worldwide. For HIV, it's 28% of the worldwide response, okay? And it's collective. It includes all of those countries that you saw previously, the traditional donors, right? The Global North, the Western donors, is who funds the Global Fund. However, as is with everywhere at the moment, they were severely cut. They are being severely cut now, and it means that their capacity to respond to the needs will be jeopardized. And that definitely relates to MSF, okay? Because if you can go to the next slide quickly and skip through. Okay, so this is, if it's okay, this is where MSF are, right? So we're in 70%, 70 plus countries. If you go to the next slide, yeah, and these are all the Global Fund countries. And then next one, okay, it's a lot of detail, but basically wherever there's a red, it's an MSF and a Global Fund overlap, okay? And in short, wherever MSF has a HIV, TB, and/or malaria project, the Global Fund are there. And the Global Fund will be covering everything. They will be covering the supplies, they will be covering staff incentives, they will be covering staff training, they will be covering the laboratories, they will be covering the innovation of products, the procurement of products. They're also including the lenacapavir, right? The long injectable PrEP, this groundbreaking opportunity that we have to really end AIDS. Global Fund are at the heart of this. Why are they at the heart of this? If you could go to the next slide. Okay, why are they at the heart of this? They're at the heart of this, as Roz mentioned, because they have been the ones who have, Gilead have said going to have access to lenacapavir to roll out. However, that means that MSF has to now go through the Global Fund to get access to lenacapavir. We can't do it for where we see the needs and where we have projects by ourselves. We have to now go through the Global Fund to do this. And the Global Fund is a dinosaur, and it's huge, and it's a development organization. It is not adaptable, flexible, and does not meet the needs of humanitarian, which is our focus and interest and our needs. So if you could skip to the next slide. These are all examples of, from the map that you saw, it's not very good on the slide, apologies, of MSF projects where we have HIV communities, people, projects, and we see issues that the Global Fund need to be aware of, and we try and advocate and draw attention to the gaps and the needs that we see for these populations. So for example, in Honduras, we pointed out to the Global Fund and to the donors, crucially, of the Global Fund, that we see now an increase in the number of the needs in terms of HIV patients due to the cuts that have taken place with PEPFAR, for example. Or in Guinea, we see issues in terms of pregnant women and the access they have to testing during their visits. MSF provides that, but the healthcare system isn't providing that. And if they are, it will be usually through the likes of the Global Fund that it will be funded. Malawi is a key one. It, for example, points out, as Charles mentioned, the key population, sex workers, won't be included in the MOH, in the Malawi government response. That is not the priority for the Malawi government, sex workers, whereas MSF has the immediate eyes, ears, can see what's happening. We need to draw attention to it. And Kenya is the same with stigma, for example, really drawing attention to some of the excluded groups that won't be on the government's agenda the way that MSF can see the need for, right? So we have the eyes, ears to really push the Global Fund to make sure that they respond. And when they're doing this rollout of lenacapavir, that it is included. A key thing just to mention about the Global Fund and why MSF would, you've got WHO, you've got Gavi, you've got lots of other big global health entities that are all being cut at the moment as well. So why work with the Global Fund, or why have this? The Global Fund, in theory, are meant to work for the people. They're meant to work with the civil society organizations and the community-based organizations. And that's why I'm saying, like MSF and the projects, what Charles, Lakshmi, Roz, Liz mentioned, is a real blind spot for the Global Fund. They're meant to cover it. It is our job or our opportunity to really make sure that they do, especially with the likes of lenacapavir, which is truly groundbreaking and can really be a game changer, for AIDS and HIV. If you go to the last slide, please. So just to conclude on that point, so only Global Fund currently is allowed to procure lenacapavir, right? They have a target or a limit of 2 million doses during 3 years. There are exceptions. PEPFAR also has access to lenacapavir. That's the US agency that I mentioned. The difference, as I say, with PEPFAR and Global Fund, PEPFAR is I shouldn't say because it's huge, but it is a US administration run agency, right, entity. That means that when you look at the US administration and what they're advocating for or putting forward, depending on religious beliefs, for example, but depending on certain key populations, and the way in which they're engaging with countries, PEPFAR and the US agency go to the MOH, they go to the government, and that's where they stop. So with lenacapavir, they say, okay, we'll give you doses as PEPFAR to those countries, but they won't. It won't be about the implementation. Whereas Global Fund should, in theory, be looking more at the implementation beyond the Ministry of Health. So there's, although PEPFAR have access, there's big question marks for MSF because that's not reaching the key populations that we work with. And then, so as I say, like the access for MSF at the moment is a real challenge. And that's where it's really crucial that we have this work. That means that we're really pushing back against this idea that it is kept with Global Fund, despite the fact that my bread and butter is Global Fund. As I say, they have real big problems. It doesn't always, and it's not good at capturing the realities that MSF sees. And I think just one key point that keeps on coming up for me is MSF is humanitarian. We see an increase in crisis and conflict all around the world. This year has taken off 100 miles a minute in this respect. You need these treatments that are really valuable for those populations. They need to be at the forefront. That needs to be in the calculation when they're looking at where to provide these medicines and these interventions that can really be crucial for these populations. And I think that's it.
Can I ask if anyone has any questions or comments before we wrap up today? Yeah, go ahead, Sarah.
Two quick questions.
Two.
One is, what does the ring do? I'm from the corporate partnerships team. I'm quite new to MSF, still learning all the different things we're doing. Obviously, you've got the injectables, you've got the tablets, but then you showed that ring. That's the first question. What is that, and what's that actually do?
Lakshmi.
Yeah, happy to take that. Thanks for your interest. So the ring, it was developed in so it will work in exactly the same way, in that it will prevent HIV, but a bit like the contraceptive ring, you put it in the vagina and it sits there, and when you have sex, you're protected. Its efficacy, so that how well it works, is not as good as obviously things like the injectable, but even the oral pill, because it wasn't very popular with young women. But the idea was a bit like in family planning to just provide choice, which empowers. So yeah, it's a ring. Does that answer the question?
Yes, it does. Thank you.
No worries.
And second question was on talking about access and stigma and stuff like that. Does MSF fund like education projects on stigma and things like that, or are we more just the like medical treatment and access? Like, how do we work hand in hand with the actual, you know, access on the ground when it comes to the taboo that still surrounds HIV?
So it's not about funding. Actually, we do have teams on the ground. We have treatment teams, but also we have community engagement teams. And among the community engagement, we have health promotion. So they actually go out there and promote all the health activities, including HIV, TB, malaria, vaccination, engage with the community. So everything is funded together as a project. So
Okay,
yes,
yeah.
there is those activities and sensitization is done.
Yeah, thank you. That's really useful.
Question. Sorry if you already explained this, but why is it just the Global Fund that has access to lenacapavir, and like why? Like, and how did they negotiate that? When did that happen? Why no one else?
Good question. No, I mean, I don't know specifically. So obviously when Gilead made it available, they signed the voluntary license, and that's restricted to certain countries. In addition to that, the only procurement mechanism they made available beyond the voluntary license, which is going to take a while. So basically, when they made the voluntary license, that basically gives permission to certain generic companies to start producing a generic version, which is cheaper, a copycat version, right, of the product. But that's going to take a couple of years to come online. So you're not going to have access to generics for like a couple of years. So that's happening. In the meantime, I guess, or in addition, there's a lot of what people wanting access. So they signed the agreement with the Global Fund because obviously they're the biggest provider in the HIV response. It makes sense for them to do that, but it's the only way to get access to now. So if MSF is going directly to Gilead and saying we want to procure lenacapavir, they will not allow us to have access. So it's only through the Global Fund.
And is it transparent how much the Global Fund procured it for? Is that
the price is not transparent?
The price is not transparent.
No, good question. Yeah, no, it's not. That's one of the because obviously as part of the SAMU project, they're funding these 5 civil society organisations in different countries. So it's like UK, US, Brazil, South Africa, and India. And they're obviously like very fast-paced, small campaigning organisations, really, who can do a lot of like the grassroots campaigning. And so they're doing quite a lot of interesting work around this, and one of their key asks is transparency of the price for the Global Fund. Yeah.
And sorry, slightly unrelated, but do the NHS have access to it?
Yes. Yeah. Okay. That's probably better for you guys.
Yeah. Actually, NHS access. Not yet.
Not at the moment. Cabotegravir we use at treatment level. For both, prevention isn't really available on the NHS. It's just in the oral forms. I don't even think we offer the ring in the NHS because it's just not popular. And a huge proportion, and it's very different to MSF populations who we see in our clinics, and it's very much men who have sex with men. So certain modalities don't apply to them. But yeah, we don't have the injectable as a preventative. We have it as treatment for HIV.
It's only cap, not then, yeah.
And is that because of price? So that's because of a nice price barrier.
Yeah.
Sorry, again, unrelated, but when the NHS gets access, they all have to publish what they paid, right? Like when the government agrees.
So
that has to be
UK
the price.
publishes the price.
They publish price.
Yeah. Okay. But they usually publish, and you might be able to answer this better than me actually, they publish their list price, right? Not the actual price. So what that means is they publish the price before they probably negotiate a discount. And that's what a lot of countries do, is they publish the list price, which is not the actual price they've negotiated because they want to keep the actual price they've negotiated confidential, because they think that by doing that they'll gain access to a better price. So you'll get access to some pricing information, but not all, right? Just, yeah.
So thanks, it's been a great session from lots of different angles. One thing I noted on there, I didn't realise this, it was only 2 million doses agreed over 3 years, right?
Yeah.
For prevention. And if you think that in many contexts you need to probably treat about 30 or 40 people with preventative injections to prevent one infection of HIV. So in order to actually scale up over 3 years, what we're looking at is actually only preventing maybe 50,000 infections of HIV, maybe 100,000. And we've at the beginning told us 1.3 million new infections every year. So effectively this amount is not really going to touch the sides in terms of HIV prevention. Although we're talking about it as this massive change, it's not yet going to have impact until it's given to those who need it and scaled up. And talking about these barriers reminded me of some of the stuff I've only read about, but from the kind of late 90s, early 2000s, when MSF was involved in some of the buyers clubs. I don't know if anyone's seen Dallas Buyers Club. Similar things were done with MSF doctors and workers taking drugs that were off patent to places, to Thailand, to South Africa. And I wonder if that's a potential next step for the team to consider, because things are going so badly.
No, I think that's a great idea. I totally agree. And I think it's the kind of thing that MSF is historically, like you said, has historically been involved in and well placed to do. And I think would be really, this is like a perfect scenario where you would do that. I think it's definitely something that's been discussed in the SAMU project, where they're trying to overcome some of these challenges. It's still like really in the, like still creating what it's going to look like and like what the campaign's going to be and how we're going to overcome these barriers and like which is the best way to do that, to maximize access, I suppose, for the most number of people. And so there's different strategies that we're looking at, and one of them has certainly been Buyers Club. I think it's something that we're going to work with the civil society groups on, because also they have also got some quite recent experience around Buyers Clubs. So there's recently been a Buyers Club for cystic fibrosis medicines that Just Treatment, a UK-based organisation, really helped set up for access to really expensive medicines for cystic fibrosis, which was really incredible. And so they have quite a lot of experience doing this with a generic based in Bangladesh. So yeah, I think it's something that's being discussed, but I don't think it's sort of decided yet. But I would love to see something like that.
Can I add my 10 pence worth on that? But also, so I think it's really important to not just think of lenacapavir on its own, as you say, that because we've got this whole toolkit, which is a bit why I wanted to kind of plod through a little bit of U equals U, because if you think about all the people who have HIV, if we just get them all undetectable, you'll actually cut out a lot of the transmissions that way. So it's like this multi-pronged approach rather than just, one drug is going to sort it all out. Clinician's point of view.
And I mean, I was thinking again the point about MSF's legitimacy and the Global Fund, like those doses, that's what they said, all those countries and 8 adopted countries, like we're pushing Global Fund to expand on this and to keep on. And the only reason we can do that is because of what we have from the ground, right? What we can say from the ground. And it's the same, what you said about, so lenacapavir, but you say the same for malaria, like the malaria vaccine, there was lots of headlines about it, but it's not, that one vaccine isn't going to solve malaria. It has to be the whole package. And it's really important that the donor countries know about that. They don't. The Global Fund in Geneva, they don't know about it, and they need to know about it from us.
Sorry, me again. How does MSF's advocacy work compared to other international organisations? Are we kind of a leader in this space with what we're doing on this, or how are we working with other organisations that are facing the same kind of barriers and challenges?
I think that I think firstly, like a lot of civil society groups have been completely decimated actually by like what's happening in global health and the cuts. There is a real like funding crisis for organisations, particularly those doing policy and advocacy work as well. and small organisations like small civil society groups, community groups are really struggling to get funding, and that includes like just all across the board. And so I think MSF is just so incredibly lucky, really, or just, you know, one of the organisations who's able to kind of have a sustainable approach to advocacy work, and obviously our work in general, because we're not reliant on doing grant applications and fundraising and all this stuff that a lot of civil society groups have to do all the time as part of their work. And so I think just purely because of that, we do end up having sort of a more sustainable approach and being a leader, I guess. And I think in HIV advocacy, we have historically been particularly around access and treatment. In HIV, we have been a kind of leader in that space. And so, yeah, I think we have been able to take on that role a bit. And just to say, in the UK, specifically, during like COVID days, when we were doing a lot of access work around access to the COVID vaccine and other things, where it was kind of like on the news all the time about patents and all these things that are like quite technical, but everybody was talking about at the time. I was working with a coalition of about 8 civil society groups, and now there's none others who have access funding to do access work like consistently. It's like just us, because they've all lost funding to do this kind of work. There's some that dabble in it every now and then, but they, to do kind of particularly with a global angle, have really lost their funding. So it's really challenging. And I think particularly for community civil society groups in some of the countries that we work in, again, like funding is just like a real challenge. They've been completely decimated.
I think the other, not unique, but I think another bit of our sort of brand is also because we can talk about the technical stuff, right? So we have that. We've also got the expertise in terms of patents and stuff. But also we have the real operational experience in conflict. Do you know what I mean? So other organisations can talk about Malawi or stuff, but we can see, okay, in Myanmar today, this is what we're seeing. You know, with displaced population. So we've kind of got a bit of a kudos because of our conflict, and also because we can really link our operations to the technical. But I think this is a key area where we do work in coalition when we can, right? Because I think this one and probably migration are probably our 2 ones that are we collaborate the most.
And also it's our legitimacy is what we do, but we're funded. It's the way we're funded. Like I can go to the Global Fund. The only reason they listen to us, or the only reason donors will say, okay, but why is MSF like interested in the Global Fund? We're not funded by the Global Fund. We have no interest in like receiving any funding from the Global Fund, and it gives us legitimacy at the table because they know we're not, you know, like we're not going to get something from the Global Fund for advocating for, I don't know, the needs of HIV projects and so forth in a country. So the independence and the neutrality that we fall under is really like, it really has some weight for those actors.
I'm so sorry to interrupt, but we're going to run over. This could be a whole session, a whole evening, an event type thing. But I'm just going to give you say thank you and give you all a round of applause for really listening. We're going to say bye. Thank you, Lakshmi. Bye bye.
Thanks, guys. Bye.
Yeah.